Good afternoon, everyone. My name is Saad Kandarian. I'm a physician scientist in the Division of Hematology with joint appointments in the Department of Immunology and Molecular Medicine, and part of the Center for Individualized Medicine High Definition Program here at Mayo Clinic. I would like to welcome you all to the Center for Individualized Medicine Grand Rounds. The SIM Grand Rounds series is designated to highlight the latest in scientific discoveries and innovation, and to demonstrate how individualized medicine is being translated into practice to meet current and future patient needs. Today, it's my pleasure and honor to introduce our presenter, Dr. Bruce Blazar. Dr. Blazar is a Regents Professor of Pediatrics in the Division of Bone Marrow Transplantation and Cell Therapy at the University of Minnesota. He's the recipient of the Children's Cancer Research Fund Land Grant Chair in Pediatric Oncology. He is also the director of the Clinical and Translational Sciences Institute and the director for the Center for Translational Medicine. Dr. Blazar has extensive background in clinical translational science research. He has world-renowned expertise in graft versus host disease, and he directs an NIH-funded preclinical basic and translational immunology and stem cell research and early phase clinical studies for the last 35 years, with particular emphasis in blood and bone marrow transplantation. Today, his presentation will focus on recognizing the biological properties of regulatory T cells that are well suited for regaining immune homeostasis, and on identifying allogeneic transplant recipients that may benefit from Treg therapies, as well as assessing the impact of CAR Tregs on acute and autoimmune like graft versus host diseases, describing the biological and outcome differences for CD4 peripheral Tregs and in vitro induced Tregs. Throughout this talk, please use the Q&A in the Zoom to submit your questions for Dr. Blazar. We have planned time for Q&A at the end of the session. For those who have not yet claimed the CME credit, the code is VAKFER. Again, this is VAKFER, and the message will be sent out in the chat as well. Now, please join me in welcoming Dr. Blazar. Dr. Blazar, we thank you for being with us and for the presentation.
I'd like to thank Dr. Kandarian for the kind invitation and a wonderful introduction. And I'm looking forward to describing what we've been doing with looking at cellular therapy to regulate adverse allogeneic immune responses that are applicable to both malignant and non-malignant diseases, particularly autoimmune diseases, which we're becoming much more interested in pursuing. Oops. For those of you who don't have familiarity with allogeneic transplantation, I've summarized it on this slide. We should note that allogeneic hematopoietic stem cell transplantation was the first efficacious anti-cancer cellular therapy. There have been more than 1.5 million stem cell transplants to date. There are more than 30,000 per year of allogeneic hematopoietic stem cell transplants. Basic principles is to use conditioning regimens to remove the host cells, the hematopoietic and immune cells, to prepare for the engraftment of the new cells and to get rid of any detrimental malignant or non-malignant cells that are causing adverse effects in the recipient. We can use radiation therapy. They don't all have to be that, but many historical have used radiation therapy, total body radiation, chemotherapy, and then a variety of antibodies that help deplete the immune cells or hematopoietic cells. A new donor cell graft is given intravenously, and then these cells provide hematopoietic cell rescue, but they also contain T cells that can cause adverse immune responses in situations where the donor and the host are not identical twins. And that is called graft versus host disease. They are alloreactive donor T cells. They can affect many organs in the body. And acute graft versus host disease, originally described as liver, skin, and gastrointestinal tract, and now recognized more as also involving the lung and the central nervous system, the hematopoietic system itself, and ovary and testes. So this is what acute graft-versus-host disease can look like. This is the early acute graft-versus-host disease, maculopapular rash. This can become very severe with desquamation and blister formation. It can involve the gut with hemorrhage and more advanced hemorrhage with as the disease progresses. Histologically, you can see that there's a separation of the epidermis and dermal cell layers. There's infiltrations in apoptotic cells that are in the process of dying. There are infiltrated cells in the liver biopsies. There's a colon biopsy where the villi are just about destroyed and they're massively infiltrated. And these are some of the pathognomonic signs. And mice have been used for many decades, since the 1970s, and simulating human graft-versus-host disease to the best that mice can do this. This is a mouse that's gotten total body radiation and mismatched bone marrow and spleen. And that has caused severe desquamation, red rash, blister formation, hunch posture. Animals have GI symptoms with diarrhea, loss of weight, and this animal is moribund. So we've been looking for a while at trying to find immunoregulatory cells that can shut off this response. A breakthrough came about in 1995 when Shimon Sakaguchi described the population of cells that had such features. And he developed these in the context of his studies in autoimmunity. And these are called regulatory T cells. They develop, there are thymus-derived versions that are CD4 positive, and they express a master transcription factor known as FOXP3, and they have a hallmark of expressing CD25, which is the IL-2 receptor. So these immunosuppressive cells can migrate into the periphery where they can control immune responses. There's a second way that these cells can be generated, which is to say that the naive cells can get out into the periphery, and under certain conditions, particularly with TGF-beta, retinoic acid, and tolerogenic peptides, they can become peripheral regulatory T cells. They don't have the same characteristics epigenetically as the thymic-derived cells, but they have the immunosuppressive properties of thymic-derived cells. And then in vitro, these cells can be generated by exposing naive cells to TGF-beta, rapamycin, and IL-2, along with anti-CD3 antibodies. So there are three different kinds, categories of these cells, and these cells can control the immune response, whether they're cells that produce cytokines that cause autoimmune diseases, anti-tumor effects, parasite and allergy of Th2, or autoimmune diseases and microbial immunity, amongst others. Conceptually, these have been viewed as in autoimmunity and graft rejection. There's a dominance of T effector cells, a minority of the T regulatory cells, so the disease is not controlled. If you were to increase the regulatory T cell number or potency to outweigh the effector cells, the concept has been you could treat autoimmunity and you could prevent graft rejection. The regulatory T cells have a number of mechanisms that can control these adverse immune responses. Some of them are summarized here. There can be inhibitory cytokines, TGF-beta I've mentioned, but also IL-10, IL-35, amongst others. They can affect metabolism by changing the metabolism of ATP and ADP to adenosine, which is suppressive. They can affect cyclic AMP, another metabolic regulator. And they can directly block conventional T cells and change calcium flux and change molecules that stimulate immune cytokines involved with immune responses. They can also kill through granzymes and perforin. And this whole process depends on IL-2 binding to the IL-2 receptor alpha chain, which is one of the trimeric chains that helps drive IL-2. And this particular IL-2 alpha chain is critical for regulatory T cells. Now, the limitations of this when we started and others started is that, first of all, polyclonal T cells, Tregs, have unknown specificities. They develop in the thymus, some of them, and they may have exposure to some autoantigens, but they may not see all of those. They may be organ specific, or they may develop in the periphery. So they have variable activation, proliferation, and suppression capabilities and specificities. A second limitation is that these are present in low frequency. In fact, you want the immune system to be able to respond, but you want these regulatory cells to prevent overly robust responses or adverse responses where the conventional cells have started to cause injury, so you don't kill the organism or the organ. These are in the mouse spleen, these are CD425 positive cells, these are CD25 high, and they're about 5 to 10% of the spleen. And you can see they express FOXP3. In human peripheral blood, these are far less frequent, more in the line of 2%. So quite a few years ago, after Shimon's paper came out, we became interested in what the potential utilization of these cells are. And I'm showing that we did studies to look at the depletion or the add back of regulatory T cells, but really the journey was much more prolonged than that. We came about this not because of Shimon's article, because I did not recall relating that to what we were interested in, but when we started to look in vitro at tolerizing the donor T cells to not recognize the host, it turned out that that tolerization process was dependent on regulatory T cells. So it was that inspired us to then ask the question whether they were critical for in vivo graft versus host disease, if you deleted them, and if you added them back, whether it can control graft versus host disease. So 2 different strains of mice. If you have, this is proportion surviving days post-transplant, no T cells, you get no death. If you have T cells and no regulatory T cell depletion, you have a certain level of acute GVHD lethality. If you deplete those regulatory T cells, even though they're only 5 to 10% of the population, you have an acceleration. So these cells naturally are trying to defend the organism against lethality. So that led to, conversely, if we added in additional regulatory T cells, instead of being 5 to 10%, now having them 50%, what would happen? And as you can see here, the T cells with no added regulatory T cells differ quite substantially from those in which regulatory T cells are added. And these cells were added after ex vivo activation and expansion. And this is really one of the very few things in hematopoietic stem cell transplantation, allogeneic, that has been highly reproducible from lab to lab to lab. And these regulatory T cells then, based on these data, and then there were 2 subsequent reports later that same year by Sam Strober's group at Stanford and by Jose Cohen's group in France that showed the same thing, and that inspired a number of us to look toward clinical translation. Now, the problem with clinical translation of these cells was that the human CD25 expression was not as clear-cut as in the mouse, where it's a completely separate population. In the humans, it was more of a continuum of CD25 expression. And it turned out the CD25 low cells and this were not regulatory, the CD25 intermediate cells. Some were regulatory and some were activated T cells, because activated T cells also express CD25. And only the CD25 brightest cells were suppressive. So this became a problem when you use peripheral blood, because that has a lot of non-regulatory T cells that are CD25 positive because they might have seen a virus or some other antigen in vivo. So what we thought about doing is using cord blood. And the reason we use cord blood is that these, we reasoned that during gestation that the fetus would be not exposed to a lot of antigens that would activate conventional T cells to upregulate CD25. And we further then looked at using a very low number of CD25 antibody-coated beads on this Miltenyi device, which would select out the highest CD25 expressors. And we reasoned that those in cord blood would be the regulatory T cells. And so the cord blood has a lower acute GVHD risk versus peripheral blood. And we reasoned it was an enrichment of this cell population that we could isolate and expand. And so crudely, when we started these studies, we had flasks. We had not adapted these to any larger vesicle, and they were grown in culture medium with AB negative serum. They had CD3 and 28 antibody-coated beads. The CD3 provides a T cell signal, receptor signal, which is required. CD28 provides a second signal, which helps stabilize the cells to produce cytokines and have a productive immune response, and they require IL-2. And then a lot release criteria shown here, which are again pretty crude: gram stain negative, endotoxin low, viability high, candidate population at least 70%, contaminating CD8 cells, which might cause graft versus host disease, less than or equal to 10%, and only 100 beads per 3 million cells, because these get infused in vivo. This was actually the first trial, true phase 1 trial in humans. There were 3 patients treated prior to this for 1 for acute GVHD and 2 for chronic GVHD in Europe that were not prophylaxis and really weren't designed to be any kind of phase 1 trial. It was compassionate use. So this was the first real phase 1 trial, first trial of cord blood regulatory T cells. So in the process of doing this, we had to make sure that the cells worked. We produced them in the GMP building, and then took immunodeficient mice. If you put in human peripheral blood mononuclear cells, the human immune system, the T cells and monocytes, will recognize the mouse as being foreign and will attack the mouse and cause what's known as xenogenetic graft versus host disease, because it's foreign cells into foreign human cells into a mouse. If you add in these expanded regulatory T cells, this was at a 1-to-1 ratio, we could rescue about half the mice. And that's pretty substantially benefit here. And you have to remember that the regulatory cells are human as well. And these cells don't all respond to the same cytokines. The mouse doesn't make a lot of IL-2 to help support these cells. They don't have the same homing and adhesion molecules, et cetera. So this was viewed as a large positive. And the FDA was satisfied with our scale up and with these preliminary data. So we were allowed to go forward with the clinical trial, which is shown here. This trial was led by Claudio Brunstein and John Wagner. This took a cord blood unit and expanded regulatory T cells for a period of 18 days. Using non-lethal conditioning regimen, patients received cord blood units. They actually received 2 cord blood units that were not matched with each other, but were 4 to 6 out of 6 matched with the recipient. And they received the T cells that were in those units, which were about 15 million cells per kilo. Phase 1 dose escalation study was done from 1 to 30 times 10 to the 5th cells per kilo. These cells were given on day +1, which wasn't really the desired time frame because it was after the T cells were given, but there was a lot of discussion at the time that if we gave the regulatory T cells before the transplant, even a day before, and there was any side effect or complication, that we would interfere with the transplant itself, and that would be a detriment to the patients. It turns out that that would not have happened. In addition, Rob Negrin and others at Stanford have given regulatory T cells before the transplant, and after conditioning, these cells will activate and expand in vivo. So you can give fresh cells and have them activate and expand in vivo before you give the T cells. In any event, a second dose was allowed on day 15. All patients received standard of care, which was mycophenolate and cyclosporin, which is a calcineurin inhibitor. And in the last 7 patients, they received rapamycin because Tregs are more resistant to rapamycin. And in fact, rapamycin can help make non-Tregs into Tregs. And so these were the 2 conditioning regimens. So we added a unknown therapy to standard of care. And when we looked at historically, there were 108 double cord blood unit transplant adult patients, and these were all adult patients with hematological malignancies, leukemias. There was a 60% incidence of acute graft versus host disease, grade 2 to 4, which is the sufficient graft versus host disease that they would generally require steroid therapy. And in the patients that got the highest dose of 3 times 10 to the 6 per kilo, because this was a phase 1 with extension, there were 18 patients, and they had a 39% incidence of acute GVHD, which was significant, although barely. Now, one of the important points is the regulatory T cells to conventional T cell ratios was only 1 to 6. And in mice, we know very well that you need a ratio of approximately 1 to 1 or 0.75 to 1 regulatory T cells to conventional T cells to be able to have a biological effect. So we thought this was far below the optimal ratio of regulatory T cells to conventional T cells. So that required that we changed our expansion process. And we had started in collaboration with Carl June, Bruce Levine, and James Riley at UPenn with antibody-coated beads. So these electrodense beads have anti-CD3 and anti-CD28 antibodies that I mentioned before. They can bind T cells and they can stimulate T cell receptor and provide the second signal. We did this because there were GMP reagents available and there was already a safety record of using beads for expanding T cells and infusing them into patients. Now, Carl and his colleagues and a grad student of his, Megan Sohashki, had taken an approach of looking at a cell line to be able to provide these two signals. And the reason for that is that the cell line also has adhesion molecules, it can produce cytokines, it could be readily manipulated, and it could be much more standardized. So this is a K562 cell line, which is from a CML patient that had been lethally irradiated and had been transduced with one of the ligands for CD28 known as CD86, which is one high affinity ligand, and CD64, which is an FC receptor. And the reason for this is that you can then load anti-CD3 antibody on it. So you get the same two signals, but you get additional signals as well. And these are called artificial antigen presenting cells. Kelly Hippen actually had the breakthrough part of this, and that is that almost everybody at that point, including us, were expanding cells about 200 to 400 fold. And then it occurred to us that the reason for that might be the timing of the stimulation. So normally people were doing this at 1 week intervals, and they were doing it because that's convenient, and that makes sense. However, as I started to think about this, that's the time of peak size of the cells. And when the cells are at peak size, they turn out to be refractory to T cell receptor signals. So in fact, that was the worst time because they would have the poorest response. So we used a formal cell sizing, and Kelly let them go until they hit their nadir again and then re-stimulated them. And you can continue to do this. This is showing through 5 stimulations, of course, over a long period of time. But when you do that, you get an iterative increase in the cell numbers. And this is log 10. And with each successive stimulation, they increase more and more. And we could get up to a 50 million fold theoretical expansion because we depopulated the cells with 5 stimulations, which was quite a large gain over what had been done conventionally by us and others. And one of the important properties is suppression. And so how well would they suppress a T cell response in vitro? And with 1 stimulation, they had a very high level of suppression, even with only 1 regulatory T cell to 4 conventional cells. This was largely maintained at 2, fell a little bit to 75% after 3 or 4, and then took a second hit after 5. And so we adapted this to use 2 stimulations where most of all the suppression was preserved, and you had this iterative expansion. So these cells were stimulated at day -17. They were stimulated again 10 days later, or 10 to 11 days later, and everything else was the same, except we started at the highest dose from before, which was 3 times 10 to the 6 per kilo, and we went up to 300 times 10 to the 6 per kilo, and that gave us a ratio of about 20 to 1. And this was a toxicity study. We wanted to know whether this would be tolerable. There was always concerns at the time that if you had any non-regulatory T cells in this inoculum, you've activated and expanded them, and they could cause more graft versus host disease. So we had to do this very cautiously. We used the mycophenolate and rapamycin based on the last trial that we had done. And when we did this, we enrolled 12 patients. This was again done by Claudio and John Wagner. They got these higher doses of regulatory T cells. And this is compared to a rapamycin MMF control. These are concurrent controls, and this was significantly different. There was one patient who had a transient rash. Biopsy was negative, but we're calling it graft versus host disease because the attending physician treated with steroids for 3 days. And so it's hard to know. But to be conservative, we call that graft versus host disease. And so these regulatory T cells have a biological effect. At similar time in Italy, Massimo Martelli was doing haploidentical regulatory T cells where he would give T cell depleted haploidentical grafts. He would give 2 million conventional T cells per kilo, which is a very high dose for haploidentical without immunosuppression. And then he would add in regulatory T cells. And he was able to show by this that the regulatory T cells also suppressed acute graft versus host disease to a level of approximately 10%. So I think with these proof of concept, we're still looking at, from what strategy we're doing, on ex vivo expansion that is cumbersome. Now, Massimo Martelli's group was working with Rob Negrin, so they gave their regulatory T cells in advance of the conventional T cells. But we were very interested in continuing to look at strategies to expand these cells so that they would have multiple applications beyond graft versus host disease. And not all patients are going to be lymphopenic. We don't necessarily want to induce lymphopenia in everybody. And so we were looking at ways of how do we selectively expand regulatory T cells over conventional T cells. And since IL-2 is a critical cytokine, this was pursued. This is just to show you that the regulatory T cells in vivo only lasted, in our hands, up to 2 weeks. And this is a dose response curve, even at the highest doses of 100 million regulatory T cells per kilogram. You get a peak response that occurs early, and then there's a progressive loss. We interpret this progressive loss, or at least I do, I'll say, due to the fact that there is no IL-2 that is being produced sufficient to drive regulatory T cells, because if you effectively suppress the conventional T cells that make the IL-2, then there's no source. And having immunosuppressive agents means that the cells are further not able to produce IL-2, and so the regulatory T cells will die if they don't have IL-2. Now you could give back IL-2, which has been done in ultra low doses first by NIH and then by a group in Baylor. Didn't really work too well for us in identifying a dose of IL-2 in the absence of regulatory T cells that would help support endogenous regulatory T cells. And I think that's illustrated in part by these mouse experiments that were done in the lab. And that is, if you give bone marrow with no T cells, the mice do well. If you have T cells, you get acute graft versus host disease. If you have regulatory T cells, you prevent that. Now, if you add in IL-2 in the form of IL-2 complexes, which is an IL-2 linked to antibody that prolongs the half-life of the IL-2, you actually substantially accelerate graft versus host disease. And if you do that in the context of Tregs, you lose the Treg effects. So titrating the amount of IL-2 is challenging. We tried many different versions of molecularly and chemically altered IL-2 to try to find something that would work. Worked in some experiments, not in others. Some groups have done better with this than we have, but we were concerned about giving IL-2 in any kind of version that would still have substantial effects on the effector cells. So we turned to this paper from Chris Garcia's lab. Chris is at Stanford, and he rationalized that if he could design an IL-2 that only binds to an IL-2 receptor expressed on regulatory T cells, he could get specific responses. Normally, wild-type IL-2 binds to its trimeric receptor, IL-2 receptor. If you then look at mutation of the receptor, it no longer can bind to wild-type IL-2, but you can then analyze mutated IL-2 to find one that binds very well to this receptor that won't bind to the conventional receptor. And by doing this, you get a selective expansion only of the cells that have this mutant receptor and this mutant protein. And that provides the selectivity. So in partnership with Rob Negrin, we did these experiments, and this was a great collaboration because everything was done by a postdoc in his lab, a graduate student in my lab, and they shared everything. And so half the experiments were done with one, half they were done with the other one. And it also shows reproducibility between the labs, which is important. So we took two different strains of mice that are differed in essentially HLA class 1 and 2 and minor antigens. The host was lethally irradiated. And then some mice received the regulatory T cells that were highly purified because the master transcription factor FOXP3 was linked to a green fluorescent protein, so you could isolate just the regulatory T cells. This also was linked to luciferase, which allows us to give a substrate, luciferin, and then the cells that express the luciferase then glow like a firefly glows. And these regulatory T cells, the cohorts that got these also got regulatory T cells that were either transduced with this orthogonal IL-2 receptor beta chain, and the beta chain is the critical target because the beta chain mutant is what helps make it regulatory cell more specific. Because it's the high affinity alpha, it's the intermediate affinity alpha unit that is critical. And this was a truncated epidermal growth factor receptor protein linked to the orthogonal IL-2 or just by itself. And the reason for this is then we could use beads to separate out the regulatory T cells by using anti-EGFR coated beads. So you get just the transductin for orthogonal IL-2 receptor or EGFR alone. And these were given on these were given 2 days prior to the conventional T cells, which were given at 5 conventional T cells to only 1 regulatory T cells. And then the orthogonal IL-2 or saline was started at the time of regulatory T cell infusion. So when you do that, if you have no regulatory T cells, they die of acute graft-versus-host disease. If you have these mutated IL-2 receptor expressing regulatory T cells with saline, they pretty much die very similarly. It's only the cells that have this mutated receptor and receive the mutated protein that have a significant benefit, showing a selectivity. And there were additional control groups I'm not showing you. And in all cases, they were significant, whether it's a relevant regulatory T cells with the mutant protein or just the mutant protein alone. So the only group that had a survival advantage was the one that we were hoping would have one, which is this group. Remembering that we gave 5 conventional T cells to only 1 regulatory T cell, we were still able to show a significant survival benefit. This led to then additional experiments to use the orthogonal IL-2 to study in vitro and how to whether it had the properties we thought it would have on expanding cells and how that would affect the function. So these are the same green regulatory T cells that can be isolated. They can be put in cell culture with beads to stimulate their growth in either orthogonal or wild type IL-2. As I mentioned, the anti-EGFR receptor selection gives you a very high proportion of regulatory T cells that are CD25 bright and express FOXP3. Now, if you add in wild type protein, they all expand to the same rate. And that's because the mutant receptor is in addition to the wild type receptor. So the wild type protein can stimulate the wild type receptor and they all expand about similarly. But if you put the orthogonal protein in, if you have non-transduced or EGFR only transduced, the fold expansion is 1. They don't really expand. But with the orthogonal protein, they expand 6-fold, and this is within 4 days. If you look at the suppression, putting in the wild type, putting in no IL-2, they do suppress, but putting in the wild type, they suppress less because the IL-2 is stimulating the responder cells that you're trying to suppress. And that's why the IL-2 doesn't work well in vivo unless you have some selectivity. But if you put in the orthogonal IL-2 in vitro, now you have a higher level of suppression and you have a preferential expansion. So it's important to not only look at graft versus host disease, which is one complication, but to see if there's effects on anti-tumor responses. We know we can get rid of graft versus host disease in a variety of techniques, including rigorous, very rigorous T cell depletion, removes all the T cells or the naive T cells, or a variety of other approaches. But those often occur at the expense of not having a graft versus leukemia effect or a donor T cell effect against the leukemia. So you can get markedly reduced graft versus host disease, but that can be at the expense of having the leukemia come back. So we did the exact same experiment, except now we added in a B-cell lymphoma that was labeled with luciferase so we could track the tumor burden. And I'll just do this first and say that if you give bone marrow with tumor that's in a lethal dose, and I can show you that in a second, conventional T cells and the orthogonal IL-2 receptor with the orthogonal protein, now you rescue animals. All the other groups die. The ones that get bone marrow with tumor die. The ones that get bone marrow tumor and conventional T cells with orthogonal IL-2 receptor Tregs, but saline die. The ones that just get conventional T cells die of acute GVHD. And bone marrow tumor and conventional T cells, again, they die of acute GVHD. So this does show both selectivity of inhibiting graft versus host disease, but also allows sufficient remaining T conventional cells that can have an anti-leukemic effect without causing GVHD lethality. And that is likely because there are fewer conventional T cells needed for an anti-tumor effect in these mouse models, which are contrived, than to cause death. So this has now led to a phase 1 plan. The orthogonal IL-2 receptor has led to a phase 1 trial that may have started already in CD19 positive malignancy cells from UPenn, where the conventional T cells are transduced to express this anti-CD19 chimeric antigen receptor and orthogonal IL-2 receptor beta chain mutant, and patients are getting orthogonal IL-2 protein. This was shown in non-human primates to be safe and to expand preferentially the cytotoxic T cells of interest. So we had been simultaneously adapting our approaches to look at chimeric antigen receptor transduction. In graft versus host disease, there really aren't very many GVHD specific antigens. In fact, even though some have been identified, if you think about it, there are quite a large number of minor antigens and other antigens that can be recognized by the host, by the donor to the host. In addition, there may be organ-specific antigens that you can't even simulate in vitro. And in order to make this broadly applicable, really antigen-specific regulatory T cells are going to be highly problematic. And one group has done those sort of studies. It took forever to grow the cells, and they really didn't have a great outcome. So we looked at doing this another way. Instead of looking for antigens to make regulatory T cells specific against, so that you could only affect the immune response of conventional T cells against those antigens, we decided to put in a chimeric antigen receptor to provide a different way of getting host-specific antigens. And I'll describe that to you in a minute. Just to mention that the regulatory T cell suppressor mechanisms, they can have metabolic catabolites that cause immunosuppression, tryptophan and other depletion, immune suppressive cytokines I mentioned, some thoughts that they may consume IL-2, so there's not enough left for conventional cells, upregulate inhibitory receptors, eat away the ligand for CD28 on the responding cells, or they can kill, as I mentioned before, by granzymes and perforin. So we took advantage of this by the chimeric antigen receptor, and this is the single chain part of an antibody that has been shown by many groups now to be able to direct specifically T cells against the antigen to which this binds. And with the intracellular signaling domains, most commonly used is CD28 that I mentioned provides a second signal. Another one is 41BB. This is a B7 Ig family member, and this is a TNF family member. And these are linked to T cell receptor zeta chain. And when you do that, if you have regulatory T cells transduced with this chimeric antigen receptor, if you culture them with the ligand expressing B cells, this is human CD19 positive B cells, they get this extra stimulus and then they become super suppressors in our hands. In addition, they have cytolytic potential. And this is showing a continuous killing curve assay. This is an incucyte assay. It measures live cells over a period of however many days you want. This was over 2 days. And the chimeric antigen receptor regulatory T cells that see the ligand in vitro and the B-cell lymphoma. So this is putting the human CD19 into a mouse B-cell lymphoma. And this is the human CD19 CAR, the one that's in the clinic, into mouse regulatory T cells. So the human chimeric antigen receptor recognizes the human ligand and it will kill it. All the other control groups had minimal killing. So the one group with specificity killed 93%. All the other groups killed less than or equal to 22%. So there was a potent ability to have both suppression and killing. And this was intriguing in being able to suppress graft versus host disease and also get rid of the leukemia. And so we took this into a model that Chris Pinnell and we generated. This is a mouse that expresses human CD19 in its B cells. And this mouse is given Cytoxin 1 dose. And then there was infused with the chimeric antigen receptor CD8 cytotoxic T cells, the EGFR cytotoxic T cells, or the human chimeric antigen receptor regulatory T cells, or the irrelevant regulatory T cells, and these are CD4 regulatory T cells. If you look on day 5, Cytoxin alone, there's CD19 lymphocytes left. The irrelevant CAR CTLs, there's still a lot of CD19 positive cells left. Same if you have regulatory T cells. But interestingly, the CAR CTLs and the CAR Tregs had a marked depletion of the target population, which was human CD19 B cells. And in this model, it causes what's known as a cytokine release syndrome death. And cytokine release syndrome is due to the release of cytokines from the killing mechanism that activates macrophages, that releases IL-1, IL-6, and there's an interferon gamma loop involved here. And we have reproducibly shown that with cytotoxic T cells alone, the human CAR, that we get 80 to 100% lethality in 6 days. And that's shown here and this is the worst of the experiments. And if you add in regulatory T cells that deplete these target cells, you don't get lethality because these are cells that suppress the cytokine release syndrome, activation of macrophages and the pro-inflammatory cytokines. And so these cells, when you give them with an equal number of CD8 CTLs, so if you give the same number of CTLs that causes 80% lethality, if you mix those with an identical number of the CD19 regulatory T cells, now you get no lethality and you get the same depletion. So these regulatory T cells are able to deplete without having the severe complication of chimeric antigen receptor T cell infusions. So we took this into a model of that simulates an autologous transplant, which is 2 strains of mice that differ only in allele that can be marked. And so this is the transgenic host, and the donor has this one allelic difference here. So we can track the cells, the same strategy as before, and then they get these tumor cells that were lymphoma that have the human CD19. With no regulatory T cells, they die of lymphoma. If you give the human CAR19 regulatory T cells, and these are highly purified, you extend the survival. Doesn't cure them, but obviously a biological effect in vivo. And if you do this with CTLs, you get even a further biological effect in vivo. And these are highly significant against the irrelevant CTLs or the irrelevant regulatory T cells. So taking this into an allogeneic model, this is the same allogeneic model as I showed you before, now with conventional T cells and Tregs of 2:1, but the same tumor. If you give the tumor, animals die. If you give the conventional T cells with the relevant regulatory T cells in the tumor, they die. They die of the lymphoma, and they have some graft versus host disease because the conventional T cells are not particularly good at the anti-lymphoma effect. Now, if you give the conventional T cells with the lymphoma, they die of graft versus host disease. And if you give the conventional T cells with the relevant regulatory T cells and the lymphoma, now all the animals lived. You know, I don't necessarily think this is fully extrapolatable to the human, but it does make the point that you can have a protection against graft versus host disease lethality, and this should actually be reversed, but the high degree of graft versus host disease lethality, you can protect against those, and you can protect against the lymphoma coming back. So we took this into a human model, and this was done by Kelly Hippen. This is taking an immunodeficient mouse strain. You can give a human lymphoma, Raji cell line that expresses human CD19, lightly irradiate the mice, give them peripheral blood, CD19 CAR regulatory T cells, support them with IL-2, and they rescue about half the mice. So clearly these cells have an anti-human lymphoma effect when passaged in vivo. And in vitro, you can take these same cells, and if you put them in with CD19 positive cell line, 75% will be killed. If you put them in with cell line that doesn't express CD19, the cells will grow. This has now been FDA and IRB approved to be translated in a phase 1 off-the-shelf cord blood product, where cord blood cells will be regulatory T cells will be transduced with human CD19 CAR, and they will be given to patients who are relapse refractory, patients who fail or are ineligible to receive commercial CARs. So the idea is that these regulatory T cell CARs will kill the lymphoma or leukemia, and without the cytokine release syndrome, without the neurotoxicity that can be seen, and will allow these patients to either get consolidated for transplant or be induced into a more prolonged remission. So in terms of autoimmune diseases, B cells are a target for many autoimmune disease therapies. We took our transgenic model and looked at a chronic graft versus host disease version of this, which is 2 mismatched strains of mice. A very low dose of T cells is given, so it doesn't kill the animals, but the T cells undergo chronic antigenic stimulation and cause autoimmune disease. They are prepared with Cytoxan and radiation. And then at day 28, when they have active disease, they're given the CD19 CAR or a relevant CAR as a therapy. And this was done by 2 people in the lab in collaboration with Chris Pinnell, who helped develop the model. And this is looking at pulmonary function, and this chronic graft versus host disease model is associated with bronchiolitis obliterans, which is an obstructive syndrome in which you can't exchange oxygen well because the bronchus is obliterated, it's fibrotic. And so you have high resistance, which means that the air has a difficult time getting into the lung, and low compliance, the lung is very stiff. And if you give control regulatory T cells, it really doesn't do very much. But if you give the CAR regulatory T cells, now you have a significant advantage over the control. So this provides an indication that the CAR regulatory T cells can be used to treat autoimmune diseases, including chronic graft versus host disease in this model, which is an antibody-driven disease. The mice develop this lung complication as well as multi-organ system complication because antibodies deposited in these tissues recruits in monocytes and macrophages, which cause fibrosis and cause the disease. So the summary of this is the congenic model. We didn't see systemic toxicities. It controlled early tumor growth and it improved survival without the need for conventional T cells. The allogeneic model had superior GVHD survival, depended on seeing the ligand, human CD19 ligand for the chimeric antigen receptor expressing cells. These cells had early expansion after allogeneic transplant. They significantly reduced activated T cells, especially in the gut. It depleted the ligand positive cells in vivo early after transplant, maintained the graft versus leukemia response. And we showed in vitro that this anti-leukemic response was perforin dependent. And this also was used to reverse pulmonary dysfunction in mice with ongoing chronic graft versus host disease. So in the last few slides, to talk about a different cell population is CD8 cells that can be induced to become regulatory cells. There are several described CD8 Treg phenotypes. This one is seen only in mouse. This is the ALK2 receptor beta chain, and molecules involved with adhesion and with NK markers that may express FOXP3 and CD103, which is involved in homing migration and adhesion. These regulatory T cells are very rare. They have dual suppressive and cytolytic functions that I'll show you. They can suppress by a variety of mechanisms, not too dissimilar from thymic-derived regulatory T cells. They can kill by a variety of mechanisms. And in mice, it have been shown that these cells can reduce acute GVHD severity, not as good as CD4 regulatory T cells, but they do reduce it, and they preserve some graft versus leukemia effect. These are the inhibitory cytokines shown here, as well as TGF-beta, the same sort of metabolic regulation by producing immunosuppressive adenosine, cytolytic molecules, et cetera. So Gemma Larson and the lab took irradiated antigen-presenting cells that were loaded with CD3, similar to what the thought process was with K562 cells. These are CD8 T cells that don't express the ALK2 receptor alpha chain. Oops, I'm sorry. And in the presence of IL-2, rapamycin, and TGF-beta, after 2 weeks, they become immunosuppressive cells. And that's shown here. They express a variable amount of FOXP3. Many of them express CD103, which I've mentioned before, and many of them express CD39, which is involved in adenosine metabolism. You can expand these. These are all human. You can expand these to a median of 700-fold in 14 days. As compared to thymic-derived CD4 regulatory T cells, they suppress modestly less well, but they suppress equally to CD4-induced regulatory T cells, and they suppress much better than CD8 cytotoxic T cells, so they're truly suppressive. When you look at the subsets of these, the CD103 positive subset was much more effective at suppression, and that is also shown here. CD103 positive induced regulatory T cells suppress better than the 103 negative and better than the CD8 CTLs. So these were in human cells, were injected in the same sort of immunodeficient mouse, along with peripheral blood mononuclear cells. And these are the CD8 induced regulatory T cells. They prolong survival. Neither the CD4 thymic-derived regulatory T cells nor the CTLs prolong survival over and above just giving peripheral blood mononuclear cells. Showing in vivo, these are immunosuppressive. These cells produce cytolytic molecules. This is granzymes and perforin. They're involved with cytolysis, both granzyme A and B, more granzyme B than A. They express perforin, TNF, and they have virtually no interferon gamma production. And these are gated on the CD8 103 positive cells, stimulated twice and assayed on day 14. When you do this stimulation process, you can take the cells at the end and you could put in 5 T cells to 1 tumor cell. And in the absence of any chimeric antigen receptor, they don't kill very well. But if you add in an antibody that simulates what a chimeric antigen receptor would do, which is to say this blinatumomab, which is a CD3, CD19 bispecific antibody, the CD19 binds to the tumor cells. It bridges with CD3 to stimulate the regulatory T cells, and now they kill. And they kill as well as cytotoxic T cells, given the same bispecific antibody. So that's stimulated Gemma to then transduce these cells with CD19 CAR. The rest of this is the same. and expand those cells and look at and isolate the EGFR positive cells. They express, again, FOXP3. They're not uniformly positive, nor would we expect them to be. And they have a high level of CD103 expression. And the chimeric antigen receptor did not increase or decrease the suppression against an allogeneic stimulator cell that doesn't express the ligand, the human CD19 ligand. Now, if you take these and you take the tumor cells and you knock out CD19 or you don't, so they either do or don't have the ligand to which the CAR is directed, it's only the cells that have the ligand that are killed, showing specificity both by the Tregs and the CARs, and there's no killing if you don't have the ligand. And this is showing the killing assay, and these are the chimeric antigen receptor regulatory T cells and cytotoxic T cells that kill versus the controls that don't kill well. And this is if you don't have the ligand, you don't kill. So these were put in vivo in the same immunodeficient mouse setting. The lymphoma is given first. Then a week later, the induced regulatory T cells or CTLs are given along with IL-2. And if you do that, the animals that got the tumor cells or the mock CTLs or the mock regulatory T cells all die. If you give the CTLs, the CD8 CTLs, you prolong survival, but actually the best survival was with the CD8 induced Tregs that express the chimeric antigen receptor, showing again, these cells can kill very well in vivo. And this is looking at the intracellular signaling domain. There's been a lot of hype that CD28 is the major molecule involved with this signaling domain. But in fact, the 4-1BB that we've been using in previous studies turned out to be superior to the CD28 intracellular signaling domain in terms of letting the animals live long-term, given tumor cells that would be rapidly lethal. And here they are at 100 days. So in this last summary, the human regulatory CD8 regulatory T cells were readily generated. They're highly expansile. They're both suppressive and cytotoxic in vitro and in vivo under destabilizing conditions, because there's a lot of discussion about how stable they would be because they're not having the same epigenetic modifications as thymic-derived regulatory T cells. They were stable in vitro. The killing was without loss of suppression. They had both killing and suppression without changing either one. They were superior to CTLs. They were superior to CD28 versions of the regulatory T cells, partially perforin dependent. And we believe these cells will have the potential to simultaneously augment GBL while suppressing GVHD. I've tried to mention people along the way. These were people from the lab that were involved in various aspects of this, collaboration with faculty here, and particularly Mehrdad, who made a lot of these vectors, along with Saad Kandarian, who's been working with us on this. And then collaborations with Stanford folks, UPenn. I didn't show data from Oxford, but we've been working very closely with them. Michael Jensen provided the vectors, and these are the funding mechanisms. And I thank you for your attention.
Thank you very much, Bruce. Very informative and inspiring presentation. So it looks like we have time for a couple of questions. We have a question. Very informative talk, thanks. Cell-based artificial antigen presenting cell system for Treg expansion is cool. In terms of bringing the technology to clinical application, what are your thoughts?
So it is in clinical application. It's been used by now a number of different laboratories. It came from Carl June's laboratory, who did it first. There's been, initially there's some concern about whether they would form tumors in vivo. Actually, that's happened once, and it's happened once when the cells were inexplicably non-irradiated. It's not happened to my knowledge on any of the irradiated cell lines. So people are making their own now, cell lines, and you can put in any one number of ligands and receptors or cytokines. So it's been quite useful, and they do work better than the beads work.
I have a question about the ortho-IL-2 story. So the ortho-IL-2 that's getting translated to the clinic, this is an effector T cells, right?
In effect, but we're in discussions with Synthekine about bringing it into regulatory T cells. And they have been very supportive of doing that. We're just trying to finish some of the preclinical data.
And then in regulatory T cells would be also with the CD19 concept, or just like
no, first we would do it without, and then the next one would be the modified ones.
Modified, yeah. Okay, looks like we have another question in the chat. Considering the cytotoxic effect of CAR Tregs, do you think they can be used in the setting of autoimmunity or transplantation?
Yeah, the chronic GVHD is an autoimmune disease. We are going to be looking at other autoimmune diseases. I think it's a natural, these cytotoxic T cells with CARs against CD19 and others are being used in humans for autoimmune diseases. It's been used in lupus. There are discussions in scleroderma. It's going to come out in a variety of other settings. We like the regulatory T cell part of this because it helps suppress the autoimmune disease while it kills some of the cells responsible for generating the autoimmune diseases. So I think that we're going to see an increase in this over time. There was a New England Journal article recently that will stimulate a lot of thought, but I think it's going to be pretty widely tried, and we'll see what the net result of that is.
Do you think that's going to be mostly targeting B cell?
B cells and plasma cells initially, just because they have an approved product that you can use.
Yeah, let's put it in Tregs instead.
Well, that's where we're going. If it's better, great. If it's not, that's fine. But I think the side effects should be less. And it has the additional advantage of the Tregs useful for some of these autoimmune diseases without the CARs. So we think that you have a dual benefit, possible a dual benefit.
Yeah, I think we can take one more question. We're already 2 minutes after. There is a question. Do you think the specificity should be towards effector T cells in this context?
The specificity of the Tregs to effector cells, for graft versus host disease and some of the for graft versus host disease, it's hard to know what the responding T cells are. The frequencies are still rather low until they expand. So it would be hard to know how to do that. What's been done in organ transplant is anti-HLA specific regulatory T cells that help suppress cells that are reacting against the graft HLA antigens. And that's probably as close as we can get right now.
Yeah, well, thank you again, Dr. Blazar, for the time for the presentation. We are a few minutes over the time, and thank you all for attending.
Thank you very much.
Have a good day. Thank you.
Take care. Bye.